The treatment of FLT3-mutated AML in fit adults has been transformed in the last decade or more by the results of two large randomized trials. Firstly, the RATIFY study showing a clinical benefit of adding midostaurin to intensive chemotherapy, and more recently, the Quantum First study showing survival benefit in patients in whom quizartinib was added to intensive chemotherapy. Importantly, in Quantum First, the benefit to patients was observed in both patients who went to transplant and those who did not. Whereas in RATIFY, the clinical benefit was confined to patients who went to transplant. So in many patients and in many people's eyes, quizartinib is a preferable upfront partner for intensive chemotherapy in such patients. But this, of course, begs a number of questions. Firstly is, can we improve the results observed? And I think it's really important to note that a study is currently running in the UK, the Optimize clinical trial. Secondly, it begs the question of whether it's possible to obtain a similar benefit in patients who are treated with rather more gentle induction regimens, which are venetoclax-based. And the results from the MD Anderson showing really high CR/CRI rates with a triplet of a venetoclax, a hypomethylating agent, and either gilteritinib or quizartinib have led to significant interest in the possibility that a triplet could replace intensive chemotherapy with either quizartinib or midostaurin. The initial encouraging results were confirmed in the Viceroy study reported in ASH with the ven/aza gilteritinib triplet, and there's a planned study which is about to launch next quarter with the UK and the US sites, notably MD Anderson, looking at ven/aza quizartinib as an induction regimen, comparing it with DA-quiz in older fit adults. And this is predicated on the notion that most of these patients will be proceeding to transplant, and therefore a strategy that has a high CR/CRI rate with modest toxicity may translate into improved survival compared with DA-quiz. And finally, I think it's really important for us to remember the core role of transplant in the management of FLT3-mutated AML. There's very important data from the Morpho trial and Quantum First showing benefit in maintenance post-transplant using FLT3 inhibitor. And I think there will be further studies ongoing about optimal deployment of post-transplant maintenance. And then looking in unfit patients, there's also some very exciting potential to use the venetoclax hypomethylating agent, quizartinib or gilteritinib triplet as the treatment of choice in preference to venetoclax azacitidine in older unfit patients with FLT3-mutated AML. These patients don't do so well with venetoclax azacitidine, and there are ongoing planned trials comparing an HMA venetoclax backbone with the aforementioned triplet. So taken together, I think we can see that the landscape of how we treat fit adults is potentially changing, possibly in the younger patients to intensify treatment, and secondly, in the older fit adults, many of whom will go to transplant anyway, looking at a venetoclax-based triplet, and then also plausibly opportunities to improve treatment options in older unfit adults.